Thank you, Chairman and Organizing Committee. I'd like to talk about the medical management of the unresectable and metastatic pNET. I'm a medical oncologist, and we not discriminate the functional or non-functional pancreatic neuroendocrine tumors if the patient recurred after the surgery or the patient initially have the metastatic disease. We plan about the treatment. Professor Jagannath mentioned about the neuroendocrine tumor has a very wide spectrum of the disease. So we have some neuroendocrine tumors, symptomatic or asymptomatic here, or metastatic or localized, sometimes well differentiated and poorly differentiated. Indolent course of the disease some patients showed. However, some patients showed the aggressive, very rapid progression of the disease. So I summarized here for the treatment options. The surgery is the main step of the treatment. The resection of the primary tumor is very important. And if unresectable, however, the cytoreductive surgery is also another option. Also debulking with the local regional therapy, such as radiofrequency ablation or embolization or chemoembolization is another option. And I will talk about the medical therapy today. And Professor Jagannath mentioned about the nuclear medicine, especially with the PRRT, and sometimes we adopt the external irradiation for palliation of the brain or bone metastasis. Actually, we decide the treatment of neuroendocrine tumors is metastatic or unresectable. We think about the type of the neuroendocrine tumors. That Freeling mentioned about the TNM staging, and also we think about the resectability and this functioning or non-functioning, and the patient performance status, and also the patients are very old ages. We think about the comorbidities and treatment options, and also the patient preference and convenience for the treatment. So we think about the treatment goal, especially first one is the symptomatic control. If patient has a symptomatic functioning pancreatic neuroendocrine tumors, or we think about the tumor controls, and we think about the quality of life, because a lot of patients with their neuroendocrine tumors live very longer with the palliative treatment, so we think about the quality of life of the patient. First of all, I mentioned about the symptom control. If the patient has a functioning neuroendocrine tumors, the study shows that octreotide rod relieves the symptoms, especially for diarrhea. They reduced the frequency of the diarrhea 4.3 to 2.5, so 42% reduction of the diarrhea frequency, and also the flushing. They reported the 84% of reduction of flushing with the octreotide rod. Also, recently, the development of the new somatostatin analogs with the ELECT study is a phase 3 study with the lanreotide autogel treatment, also reduced the short-acting somatostatin analogs rescue therapy with the carcinoid syndromes, and also the other new somatostatin analogs, especially is pasireotide, also controls flushing and diarrhea in patients with the carcinoid syndrome. Especially the interesting thing is that patients are already refractory or resistant to previous octreotide rod. I mentioned about the tumor control. Octreotide rod also prolongs the tumor time to tumor progression. The famous PROMISE study with the patient with a well-differentiated mid-gun neuroendocrine tumors, the octreotide rod prolongs the time to progression up to 14 months compared to the placebos, 6 months. Also, there's a 66% reduction of the tumor progression. It's the same as the functioning mid-gut tumors or the non-functioning mid-gut tumors, the same efficacy they showed here. Also, the clarinet study, lanreotide autogel also prolongs progression-free survival compared to the placebo arm, especially the median is not reached, and also the placebo is 18 months here. So another somatostatin analogs control the tumors in neuroendocrine tumors. Also, we summarize the advanced pancreatitis is resectable, especially if they have the liver metastasis. Professor Jonas mentioned about the surgery, and also unresectable with the symptoms that we apply the local regional therapy such as RFA or embolization. And then I moved to the medical treatment and radiation therapy with the everolimus and sunitinib. Two agents is now, after the 2010, we have the two targeted agents is very active for the pancreatic neuroendocrine tumors. Especially the everolimus is the data from the RADIANT-3 studies. They shows that prolong the progression-free survival up to the 11 months compared to the placebos 4.6 months, so the 65% reduction of the tumor progression. Also, at the same time, we have the sunitinib. It's an angiogenic and a multi-targeted agent, therapy agent, also shows the prolongation of the progression-free survival in pancreatic neuroendocrine tumors. Especially progression-free survival, sunitinib shows the 11.4 months compared to the placebos, 5.5 months, so such as the 58% reduction of the tumor progression is the same paper in New England Journal of Medicine 2011. And also the subgroup analysis of the RADIANT-3 study, the everolimus and the pancreatic neuroendocrine tumors, also the everolimus showed the benefit regardless of the prior treatment or prior long-acting somatostatin analog use. Also, there's similar data with the sunitinib subgroup analysis. So they shows this, regardless the benefit of the sunitinib. Here, the prior somatostatin analogs or these other systemic regimens. So we have two potent new targeted agents for pancreatic neuroendocrine tumors, especially the result is from the placebo-controlled phase 3 study. Everolimus also has as a targeted agent, has a common adverse event such as stomatitis, rash, and fatigue. And the sunitinib, as the common adverse event was diarrhea, nausea, and asthenia. So with these all the data and the adverse event, the guidelines such as the national NCCN and SMO and ENS, they recommend the use of targeted agents, such especially for everolimus, is the treatment option for failure of the chemotherapy, or they can consider as a first-line therapy in selected cases. And sunitinib, the main indication as a second or third line, they recommend, and also maybe should be considered as a first-line therapy in the very selected cases. However, two studies have some kind of pitfalls here, so they have not head-to-head comparison between the everolimus and sunitinib, and also the studies do not show the validated predictive biomarkers, especially in RADIANT-3 study. Everolimus improves progression-free survival. However, especially their baseline chromogranin A level or the neuron-specific enolase levels are not affected here. Also, the sunitinib shows the possibility of the VEGFR, interleukin, a lot of the biomarkers correlate with outcomes. However, it's not still conclusive here. And I moved to the G3 tumors, such as so-called neuroendocrine carcinoma. At this type of tumors, the targeted agents are not recommended. Sometimes G3 tumors with functioning carcinoid syndromes, the combination with the somatostatin analogs are recommended. Usually targeted agents are not recommended, and the chemotherapy is the treatment of choice. Especially chemotherapy is a main stem is cisplatin based, and this retrospective analysis showed the cisplatin and the carboplatin based treatment. This response rate was 30 to 50%, and the higher the Ki-67 proliferation index, the higher the response rate. However, there is no difference here. Anyway, the promising new combination is capecitabine and temozolomide for the pancreatic neuroendocrine tumors. And also a lot of studies are ongoing, especially this study shows that especially carcinoid tumors, they had the response rate of 33% and 80% of complete response. And for the pancreatic neuroendocrine tumors, it also shows a 36% of the response rate. So also a lot of the ongoing trials, especially with the everolimus-based studies such as pNET or Roldig or for the lung cancer studies are ongoing, and also the sunitinib for G3 studies are ongoing. However, we do not use in practice. I mentioned about the PRRT for NET. So actually, the Professor Jagannath mentioned there's usually the response rate was up to the 37%, with a lot of the agents as a higher response rate nowadays. Usually the tolerability is good. However, so same as a randomized control study is not performed, and also the very limited centers, especially unfortunately in Korea we don't have no PRRT yet, so a lot of these the limitations for the PRRT treatment. So in my conclusions, anyway, as a surgeon, and the medical oncologist, they do not treat the patient their own. So we have to collaborate, work with the endocrinologist and radiation oncologist in nuclear medicine, especially radiology for intervention. As well as pathology is the first step and very important step to guide the treatment scheme for the patient. Also the medical oncologist, myself, so has a role for the treatment. Also the surgery is the primary curative approach for the patient. So for the treatment of neuroendocrine tumors, the multidisciplinary approach is essential. Thank you very much for your attention.